Okay, welcome back to the innovation stage. This afternoon, it's all about mainstreaming universal response services. So you've heard a lot about proactive preventative care services in the community, and you've heard all about what's happening in Wales. But we have a really brilliant project and collaboration and partnership with our NHS colleagues, which I want to just update you from last year. So you'll recall if you were at conference last year, we started to look at the universal response and the digital support tool. You'll see on the screen that this was a collaboration with NHS Improvement, our colleagues in Warrington, our ambulance services, and it was looking at that decision support tool in all of our monitoring centres. But quite rapidly, as we went into winter, we started to find that our 999 services were really stretched, like we spoke about this morning. And then that come a crisis. So in October 2022, Amanda Pritchard, like I said this morning, mandated our tech responder services, which has been brilliant. I'm not going to go into detail because I've got some fabulous speakers to talk about the work that we've done, but the work that we're also going to be doing moving forward. But one of the things we need to remember is, if you've been in the plenary, you've heard Matthew Wynne talking about the emergency recovering emergency services. We are part of that. We're not something that sits outside of it. And for many of you sitting in the audience, we've absolutely wanted this for many, many years, that we're seen as equals in that whole wraparound recovery. Universal Response Services is tech responders 24/7. It is the urgent care response teams in your communities, triaging people into the right care at the right time. I have Alison sitting in my audience, who used to be my manager many years ago, when we used to talk about this, about how housing and others can be that main part of the wraparound care. We're eventually getting there, and we're eventually getting recognised for our work. So I'm not going to say much more. We have a dial-in. Caroline Williams has been one of the key fundamental people within our programme. She sits in the Integrated Care Board, but she also sits in the local authority, and she does 1 day a week in NHS England. So you can start to see the drive from our health colleagues about how we really want to make proactive, personalised services. So I'm going to put the video on. She's coming tonight, but she's actually in an interview all day to become a DAS. So good luck to Caroline, but you know what? I would hate to lose her from my project. So Caroline Williams. Okay. Oh, here she is.
Good afternoon, everybody. It's a pleasure to see you all at today's conference, and apologies that I can't be with you in person, but I'm looking forward to meeting many of you tomorrow. I'm Caroline Williams, and I'm the Director for Integrated Care in Warrington, which is one of our 9 places within the Cheshire and Mersey footprint. And I'm delighted to come and join you today to talk about how we've placed the community falls response offer at the heart of our wider offer around intermediate care, where we offer a series of complementary services, including reablement at home, bed-based reablement, urgent community response, care call, which is our pendant alarm system, telecare, assisted living, and falls prevention, all in one integrated offer that provides service for the population of Warrington 7 days a week, 365 days a year. Working in partnership, all of these services, including the falls response services, support the same cohort of people who have the same challenges and we are seeking to achieve the same outcome for our population. That's living well independently at home wherever possible. In turn, our approach is delivering a reduction in the potentially avoidable ambulance conveyances, a rapid escalation to ambulance services supporting access to emergency care when people need it, an improved speed of discharge for those people who have been admitted to hospital, and ensuring that discharge to the right place for therapy and support, particularly focusing on the outcomes for people in a place that they call home. This is supporting a consequent reduction in number, length and complexity of packages of domiciliary care in the borough, delaying the onset of long-term bed-based care, and most importantly of all, a significant improvement in quality of life outcomes for this vulnerable cohort of people. In terms of our journey to get to the place that we are now, that's not to say that we don't have big ambitions to develop even further and increase our offer for our population. Our journey actually started back in 2019 when the NHS long-term plan outlined a clear expectation to increase the capacity and responsiveness of community and intermediate care services. We were fortunate in Warrington to be one of the 7 national accelerated sites selected to trial the integration of rapid response services across health and social care. NHS England's investment of £2 million brought together a range of statutory agencies across Warrington, including acute and primary care professionals within Warrington Council, our community partner, Bridgewater Community and North West Ambulance Service, to provide effective support and tailored and responsive turnaround for people in need of care and supporting the unnecessary attendance at hospital wherever possible. Uniquely, our urgent community response service is connected with Care Call, our community alarm service, and also our council's falls response services, working together to enable people to access a range of services that best meets their needs at home. Our intent was deliberate in connecting these 2 services that previously had operated as 2 separate services, and they have both been brought together under one portfolio of services within an intermediate care, and more significantly under one leadership and management structure within the borough. What we've learnt through this experience of bringing together a predominantly health needs focused service with a predominantly community focused and facing service is that a clinical response to people's needs is not always what's required, and our thinking has shifted significantly to the right response at the right time being the absolutely critical thing that makes a difference to people. Communication between all our services has been imperative, and certainly in the early days it was really important to support everybody to understand the unique offer that each had to bring to the table, and being very clear that everybody has a seat at the table and everybody at the table is equal, and bringing that shared understanding of what unique skills and capabilities that people bring to the offer. So regular conversations and communication to understand what the offers were was our initial starting point, and then we worked much more closely together in practice, visiting cases and actually having real-time conversations about, well, that's what I could offer as a falls responder, oh, and that's what I could offer you as a clinician, and then working together to figure out what somebody needed and reflecting on the things that had went well, and as well as with anything that's new and different, reflecting on the things that didn't go so well and learning from them. And I think this was where our biggest learning was in learning from each other, but also not being afraid to challenge and to be curious with our colleagues about how we could best meet the needs of people. Having been through the journey, I think it's with great pride that our patients or service users in Warrington, depending on your preference, is that they often say that our service is referred to as first class in making the smooth access to services in somebody's urgent need, but also having dealt with the urgent need, also actually looking at how to prevent a need escalating and it becoming urgent again in the future, which patients really feel is an absolutely worthwhile element of the service that they really appreciate. In terms of the outcomes for people and what they receive from the service is typically, if they press their pendant alarm, a response within 30 minutes, whether it be day or night, as say 24 hours a day, 365 days a year, somebody will be on site to understand their needs, support those needs, and wherever possible, support them to remain at home, operating this integrated model between our pendant service, our falls response service, and our urgent crisis response service. 85% of calls handled by this community offer result in people being successfully lifted, treated, and remaining at home. That's clearly very significant for our population, but equally for our system, the partnering approach that we have between our tech and UCR services, rooted in our home first philosophy, offers a credible alternative to an ambulance call and potentially a hospital attendance for people, and in doing so saves £250 for each person that isn't attended by ambulance, £300 per person that doesn't attend our emergency department, and a modest £400 per night for people who don't require a hospital stay. As we know, hospital stays are often frequently greater than a one-night stay, so those financial benefits are even more significant for people whose long lengths of stay would have been avoided. Not only do our service users and patients find that our service is incredibly worthwhile in supporting folk to remain at home, but we also have some great feedback from our ambulance service who also hugely appreciate the contribution that we make to not only supporting people to remain well and independently at home, but also arriving on scene within that 30-minute window, and our ability then to connect with the ambulance service, that if there is an escalating need or a change in need, or a need that wasn't apparent when somebody called on the telephone, we're able to convey that to our ambulance colleagues and assist in them being able to be on site sooner where required to better meet people's needs. So that's in a nutshell our journey in Warrington that we've come on, and there are colleagues of mine in the audience with you that should you have any queries, anything more that you'd like to know, they will be more than happy to respond to and discuss further with you. And I myself will be on site tomorrow and look forward to speaking with many of you regarding the real contribution and the strength of offer that we can make to our population in collaborating and working together between tech services and health and social care services, and seeing them as one continuum of service and one integrated offer that best supports people's needs, delivers best outcomes for people, and most significantly is delivering those outcomes for people at home, which is where most people want to be and want to remain. So thank you for your time this afternoon, and thank you for listening, and I hope it's prompted some thoughts and questions.
I'm sure you'll all agree that this isn't just a partnership and an integration of services, but it's real outcomes for people in the communities. You can see how health, housing and social care are all gelling together as an integrated service. Caroline will be around, and if we've got any questions in the Q&A, we've got two colleagues here. But now I'm going to hand over to one of our headline sponsors, Taking Care. Steve Gates is the MD of Taking Care, and he's going to talk about data. We talk about data and we think about digital, but he's going to talk about the richness of 211 monitoring centres who are working alongside Caroline of delivering integrated care services and how we really use data from those platforms. So over to you, Steve.
Thank you, Alison. Greatly appreciated. As Alison said, I'm slightly worried that as we've talked and listened about data, we often talk about it very much in terms of a digital future. So Sarah, president of ADAS, said in the main hall, she said prevention and proaction can be enabled by digital data. And I don't know how you feel about that when you hear about that. Taking care, we're on a digital journey. We're primarily private pay. So we're absolutely at the front end in terms of introducing that innovation to new customers. But equally, most of our existing customers are analog customers. And therefore, I think we should take it upon ourselves as a group, as an industry, to say, well, what can we learn? What can we predict? And how can we be proactive with the data that our analog customers provide us and have provided us for years and years? Because digital will be great. It's the future, but it's going to take us years to build up a really robust data set, and yet we are all sitting on top of that with our analog service users and customers. We came across the work of a professor, Imperial College in London, David Hand, who talks about dark data. And he says the definition of dark data is the data you've got sitting inside your organization that nobody thinks has got any value, so they don't do anything with it. And he said the way of getting the benefits of that dark data is you simply need to ask the right questions. And that will then give you a whole set of new value from the data you've got at the moment sitting inside your organizations. So we took that as a challenge. We thought, right, we're well up for a challenge like this. And we got a couple of data scientists. Now, again, it's been really interesting in terms of listening to the conversation today and last night. A lot of it is about the new digital skills that we're going to need as an industry. So we plucked some of these data scientists, like, pointy-haired people, and we said, right, we're going to give you 5 years worth of button presses and the reasons for those presses. And what we want to know from you is, can you predict, can you forecast what might happen in the future based on those button presses? I think that's a tough gig. As we know, analog pendants are either on or off. Someone's either pressed them or the fall detector's gone, or they're not there. So we allied all of the button presses with the reasons for that, and we gave this group of data scientists 1.5 million lines of code. And we said, because we primarily work with private pay customers, we know that when something happens to them, they're going to phone and cancel our service because they're going to want to cancel their direct debit. And our teams are really good when they do that at finding out the reason for cancellation. So within this data set, we're going to give you some people that cancelled due to death and cancelled due to moving to a care home. And what we want you to do is to see if there is a pattern of presses that precedes that, which should allow us to forecast something in the future. So they went away, they do what data scientists do, don't ask me, it's all very technical. They do what they call survival analysis, which is you take a group of people and you work with them and you find out when something happens, how are they different from the group around them that allowed the other group to survive and those people didn't. And again, out of nowhere almost, out of our analog data, came this really clear indication that you can predict both death and moving to a care home based on analog data. We thought it would be to do with 999 calls. It's not. Funnily enough, interestingly enough, neither of those data sets had 999 calls as a great predictor. Far, far more subtle. So we've rolled that up, we've written that in a report. We've done it not because you have to use us in any way, we don't want to use taking care. We've done it so you can take a very similar philosophy and apply it to your analog data so that you can start, as Alison said, to predict and be proactive and preventive using current data. So what we're going to do is we're going to basically ask the question which says, if this is what somebody looks like before they cancel due to death or moving to a care home, how many of our existing customers have we got who look like they're on that pattern? And who, if we intervene a bit earlier, maybe either through direct intervention or through their family, we can actually avoid or delay that event happening. So we think this is hugely important for us as an industry because it's something we can do to be predictive and proactive and preventive here and now based on the very most basic analog data. So all in a report on our website. We'd love to talk to you about it. Deliberately designed so you can take this, you can do this, you can be confident in your analog data that you will find those patterns. They'll be different from ours because you've got different service users than ours, but I think we can make a huge contribution here and now, proactive and preventive, all based on analog alarm data, and can contribute to what Alison's talking about. What we're going to talk about is how we foresee demand, how we manage it much better. Thank you very much, Alison.
Thank you, Steve. And I think everybody will agree that that's quite game-changing when we're looking at our response services and the data that we hold in the platforms. We can use that now, Steve, and I think we can use it in this project and as we roll it out, Claire. Our next speaker is our Head of Quality and Improvement, Helen Rudkin, and she's going to tell you where we've got to in terms of our decision support tool and some of the work that we're doing of rolling out the responder services. So over to you, Helen.
Hello, can you all hear me? Perfect. Hello, as Alison said, my name's Helen Rudkin. I'm the Head of Quality and Improvement for TEC Quality. So TEC Quality manages the auditing scheme on behalf of the TSA, and we're a subsidiary of the TSA, and that means that we have separate governance and we have a separate board, and that means that we have impartiality of the scheme. So it's the only TEC scheme that's actually accredited to UCAS. And with nearly 200 different tech providers and suppliers overall contribute to the scheme. You'll notice as you go around today with the exhibitors, we have actual signs up on the front of their stalls saying QSF certified. So it's really important that as you're moving around the exhibition today that you notice that. So embedding quality and improvement into our service delivery is really, really important into our service user, and the organisation is forefront to the audit process. We're an outcome-based scheme, so you'll hear that. We're really all about the person, it's person-centred, and we continually evolve and develop the scheme along with industry challenges. So that's with health, social care, housing, and anything within terms of A2D and how we're moving as an industry. We do allow you to be unique, so we don't actually say exactly what you need to do. It's not like the old code of practice that we had in 2017, which was a real tick box exercise. We really want you to develop your services. We don't want to stifle innovation as we go forwards within our scheme. You'll find now increasingly that we're cited in tender frameworks and in local authority contracts. So you'll see that more and more as we go forward. We've got a few consortium tender frameworks here at NHS SBS where we're actually mandated in there. And the scheme itself goes through a UCAS audit each year, so it's very robust in what we deliver and we're very agile as we move forwards. So I'll just keep my slides keeping up with me. So we started this project. It was originally a 100-day project back in October 2021, and it was titled Working in Collaboration to Reduce the Burden of Pendant Alarms in the 999. And it progressed over the year. We had a project scope in what we needed to produce. So we had a decision support tool originally was what we was going to look at. For the tech providers, so that's for the monitoring centres. As we went through the scope, we looked at lots of different ways of developing and creating a decision support tool. But as our industry is very niche, we wanted to make it really relevant to the tech monitoring centres that we have, thinking about the fact that we have non-clinical operators that actually operate in these centres. We needed to test and trial the tool with our tech providers, and we needed to make sure it was robust in that it had good referral arrangements going forwards and that we had the pathways were obvious to our operators in that way. And as part of the project, we wanted to include access to Service Finder, and I'll talk to you a little bit about that in a minute as we go forwards in there. You'll see on the top we had lots of collaboration. We had a big steering group to start with from NWAS. We had our AACE colleagues from the ambulance service of chief execs. We also had ADAS intervention in there, and we had our providers at the bottom who were really instrumental as we went through and created and developed the decision support tool in moving that forwards. It went through lots of governance. It went through our own tech quality governance. It also went through the London Ambulance governance, and it went through the MHRA 3 times. Okay, so we went backwards and forwards quite a while we designed and developed the tool, just to make sure it was relevant and it didn't actually sit into anything that was going to be a medical device. It's really simple, and I'll talk to you a little bit about that as we go forwards, but it's really, really effective. So this was the project scope. This was what we set out to do in October 2021. And I'll talk through this. If you're from a tech provider, you'll understand this a little bit more. If you're from health, we'll explain it for you. So when we say devices activated by the service user, this could be quite a lot of different technology that comes into the monitoring centre. So it could be falls equipment, but it could be sort of environmental centres as well. Health tend to talk about pendant alarms, a very old way of talking about our alarm systems that we have now in people's homes. They're not all pendant alarms anymore. So lots of different technology involved in that. And then we talk about alarm receiving centre response. And again, we have different types of alarm receiving centres. So we have our private pay and we have regional, more local authority providers that provide that monitoring centre. But they also take in, again, lots of different technology, but things from hardwired. So we've got the housing providers coming into there. But on this diagram, we're particularly looking and thinking about health. So health that might need a response at the end of that call. So the operator will take the call and they will look at the level of risk and urgency determined. And we have high, medium and low. And you can see we've slipped inside there the pathway decision support tool. So this is where it sits within this flow across in terms of monitoring centres. We check the risk and urgency, and then we determine what that service is required. And by doing that, we give you access to the NHS DOS or Service Finder to allocate or to find your services. So things like UCRs, pharmacies, that sort of thing that's actually on that Service Finder. The most important thing about this diagram here is the end, the 999, the urgent community response, UCR, the responder, which is our tech responder, and our family carers or warden, because this is where our calls always reach to. And historically, we always used to end up with it being 999, which was the end of that process. But that's not right anymore. It's changed. We've noticed that significantly over the last year. So 999 now feed back into UCRs, and we know lots of you probably in the audience already are taking off the stack already for 999. You've got that integration working. UCRs come back down into tech response. We saw a brilliant example in Warrington about what they're doing in Warrington and how they're really using their tech response service with the UCR to get that real good, strong collaboration. And not forgetting our family carers and informal network that sits at the bottom, because quite often our calls never get to 999. We start off with a family caller and they're the ones that go out to them. Remembering that not all alarm receiving centres have the access to a tech monitoring centre. If you're a national provider, you may have contracts in certain areas, but you might not have that coverage across the national sort of footprint of what you're responding to. Across the bottom, you'll see Alarm Receiving Centre keeps in touch with service users, and this is our check-in for deterioration process. We've heard about long lies and the length of time people might be on the floor. It's really important. It's a real good safety measure and really beneficial outcome for that service user if you're checking at periods that person to make sure their condition hasn't changed or deteriorated, and then you can escalate it to the responder service or escalate the response to 999, whichever is relevant at that time. So the decision support tool, like I said, we developed it and we tested it with our 5 sites at the bottom that you saw. We tested in July, August time, and it was a real eye-opener when we did that. We found lots of things around what was ready. It was a quick, sharp 10-day test of the decision support tool. And what we found when we took that back is at that point, the UCRs weren't ready. They weren't ready on the national footprint to take those referrals in. What we did find, though, was very, very valuable was our tech response services and how much they play a huge part of reducing that burden on the 999 services. They were fundamentally propping up the NHS and continue to do that now. And this is where you'll start to see how we sort of really start to integrate our services and what that looks like. The whole idea of the decision support tool was to ensure that we had consistency of call handling across the tech sector. We listen to calls through the audit process and we want to make sure they're not only delivered timely within KPIs, but they are quality. The operator understands what that is and where that response needs to go, and that they're really quality calls. And our auditors will listen to calls when they're out on site or when they're doing our annual audits as well. And we needed to improve the quality of appropriate referrals and to the right service. So right service, right response, right time is what we really want to drive forwards on this. I'll talk to you about Service Finder on the next slide. We trained and rolled out the training from December 2022. So we have the decision support tool. We have guidance. We have a template for you to roll out. So it was but really based on cascading this out through a train-the-trainer approach, cascading this out to your staff. Once we trained your sort of trainer or manager of your monitoring centre. So we have guidance on there. We make it really easy for you to do that with all the notes that you need to make sure you're pulling out when you're delivering that training within your own teams. We have a decision support tool page on our website, so Tech Quality into Google will bring up the website specific to us, and it's a closed page, so it's only for those that are QSF certified at this moment in time, because we need to ensure that we're rolling out that training and that training is quality. The next training session is on the 17th of April. If you're interested in coming to that session, if you're QSF certified and haven't done it, then you need to do it, because we don't give you access to the page or the materials until you have. If you're on your QSF journey, then come and talk to myself or my team. We are available, or talk to us through the app and we'll set up a meeting with you. So in terms of the NHS Service Finder, this is the first time that tech providers have had access to the Service Finder. So normally, people only with an NHS Health email address will get access to the Service Finder. But we have 2 templates. Template A means that you can actually get your service on, template A is so that you can access Service Finder. So it means that particularly if you're national or regional, whatever that is, you can put your service user's postcode into Service Finder and it will bring up the local urgent community response teams, as well as other NHS providers or services that are local to that. Template B allows you to put your service on Service Finder. So we want this integration to work 2 ways. We know we want to be able to reach out to health, but also we want them to be able to refer into you. So if they've come across an issue, if they're the district nurse and they're out on site, they want to know what the local tech service is, they are going to be able to access to you. We've only started to put that on there the last couple of weeks. Template A, people have been live on. Template B, we're just starting to move that forwards now. So you can see already how we're developing and creating and moving forward with this project. So I don't need to talk to you too much about the challenges. You all understand the horrendous challenges we had as we went into October 2022, a year on from where that project first started. We saw lots of issues around ambulance times, call operators answering the calls, so operators are sitting on waiting just to get through to 999 before we've even got as far as to push that call through and to get a response. And then they were sitting, we had stories coming across the national picture ranging from 6 hours, 18 hours where the ambulance has not been able to arrive. And so it's really important that this project is pushed forward so we can start to use the urgent community response teams to help us to support those service users that don't actually need an ambulance service, but sometimes you just get to the end of that chain and there's nowhere else to go. 999 is your only option. But pulling that back, the UCRs are going to be really, really important. So we saw the mandate from Amanda Pritchard. The letter went out from Amanda Pritchard in October 2022, alongside the winter pressures document as well. And it was really about improving that system efficiency, reducing the capacity or the impact on the ambulance services, making them more available for your Cat 1s, your Cat 2s, and allowing the Cat 3s, Cat 4s to be moved elsewhere, to be moved into the urgent community response teams. And one of the most significant things about the document is the TSA quality standards framework was mandated within this, that providers are certified to the TSA quality standards framework, and which is our UCAS government scheme. And you can see now the relevance in me talking to you earlier about the tech quality and what we stand for. In the middle, we looked at home assessments as well. So we completed by the Tech Response Service. So this is, as you know, our Tech Responder Service have that huge value that they walk in the door and they pick up things straight away. So they understand the environmental issues. They understand if they make someone a cup of tea that the milk's out of date and something's not quite right here. So they start to pick up things a lot more that might be more community, that they can refer on within community. And that could be sort of local authorities, it could be day centres, Age UK, that sort of thing. So they understand generally the region, the environment that surrounds them that can help people to live more independently in communities and just give them that little bit of sort of strength to stay in communities and live purposeful lives. So the mandate is really important. It is about being tech certified throughout that. And within the documentation that we have this document that AACE put together around the falls, about the falls pyramid. So you'll see in this in level 1, it will generally be a tech responder service that can complete a level 1. So it's a low sort of acuity, could be a falls, non-injured falls, not always falls, UCRs will deal with, but on this example, level 1 falls, our tech responders will go out to. Level 2 is more where you get the issues where there might be some low-level health, so a minor injury, it could be a skin tear, and some of our tech response services are already at a level 2. They have gone that little bit step further forwards, they're taking observations, they are doing some of that work. And again, you'll hear tomorrow, Progress are on Knowledge and Network session tomorrow, and they will talk to you about where they're at in terms of level 2. And then we have level 3, which will be your hospitals, your ambulance calls. So they will always go. So when we have a look at the decision support tool, it always says in there, if in doubt, you call 999. If you can't get the answer from the decision support tool, 999 is where you need to take it. So when that call comes in and the operator takes that call, they will first of all listen to what's happening. They'll take on what the presenting conditions are. The decision support tool also helps them to ask appropriate questions. So just to push a little bit further to get them all the information that they need to make that right judgment and to make that appropriate referral pathway. So this is what a tech responder service offers looks like. We are generally always 24 hours a day. There's not many that aren't. And how this complements is our urgent community responder teams work from 8 o'clock in the morning until 8 o'clock in the evening. So tech responder services are already really, really valuable in that they're available in the evenings to go out and to be eyes on that site. Most importantly, they go through a lot of training, but they offer that wraparound response service and they offer that holistic assessment. They pick up those things. And again, tomorrow in the Knowledge and Network session, we'll be rolling out what that holistic assessment looks like, and it will be part of the decision support tool page on our tech quality website. Most importantly, though, it provides better outcomes and service for people. Our KPIs for the Tech Responder module is that they arrive on site within 45 minutes. In rural areas, it's 60 minutes. Okay, so we know that if we can get to somebody before that hour, you know, the chances of them having that long lie, that actual going into the ambulance system, into a hospital system, and then being stuck with discharge, that just extends. So if we can get to them within that first hour, that's your golden hour to try and keep people at home and treated and safe within the communities. And that will obviously avoid the clogging of the hospitals and ambulance service as we go forwards. So in terms of the impact of the 999 project, it's been huge over the last year. And as I said, you can see already, and you'll have felt that already, is that fluidity of the referral pathways and how we're working and integrating, how we're much more cohesive, collaborating with our health, our social care colleagues, how that's really starting to pull together is really, really important. What we said when we rolled out the training is that the UCRs aren't ready yet. This is a tech sector, you know, get yourselves ready for when UCRs are ready to take those referrals. But already we've seen some really good relationship building, and in local and regional areas we can see some really good collaboration working. In the east of England, we've done a case study just recently with Colchester. That's on the app as well, so you can have a look at that. And that's a new organisation that's coming to QSF and really using that and the benefits of QSF to keep them forwards and also to gain the contracts as we go forwards. It does provide that consistent approach and reduces unnecessary and inappropriate calls to the ambulance service. Commissioners are much more now aware of tech quality and the quality standards framework, and Claire is going to expand a little bit more about the evaluation as we go forward of the project in a little while. So what are the next steps for tech services and the next steps for you? If you're QSF certified, then make sure you've completed the training. We've got a new session rolling out in April, so contact us if you haven't done that. We do keep emailing everybody out to say that training's available. If you're not on your QSF journey yet and you want to have some more information, by all means come and talk to me and I can talk you through some of the work that we're doing. We've got some QSF journey groups which are really helpful. So if you're joining the QSF, we've got some people already on that journey. We put you in a group, which is really helpful because it means you can share experiences, you can talk to each other. We will help and support you like no other to get you through the QSF. But it's a really nice way of doing it. It keeps you on track, it keeps you motivated, and you learn so much on the groups. It's a nice, interesting, but informal way of completing the quality standards framework. If you're QSF certified, then by all means contact your local UCR service and start to build those relationships. It's really, really important, and we've seen quite a lot of really good work come out of those local relationships. And thinking about whether you can expand or enhance your current tech service to help and complement UCRs as they come together and go forwards. And as for the future, special interest groups, we always run special interest groups. There will be a new special interest group, which will be Special Interest Group 20. And we will also be revising our virtual telehealth, which will become telehealth and virtual ward response module. And we will be looking at suppliers as well. That will be revised as well. And so, as my email address, any questions, please come back to me and I'll be happy to answer them. Thank you.
She's been busy. Helen's been really busy in post for a year now, but a background in tech. So some of the work we've been doing with our colleagues has been really fundamental, and now we've got some solid foundations to roll out. But I'm delighted now to welcome Claire Lang, Urgent Community Response Policy and Delivery Lead for NHS England. So over to you, Claire.
Thanks, Alison. Can I just get somebody to give me a bit of a wave if you can hear us? Lots of waves, fantastic, lots of smiley faces. So, hi everybody, as Alison says, my name's Claire Lang and I'm the Delivery and Policy Lead for Urgent Community Response. If you're not sure what Urgent Community Response is, that's absolutely fine. I'll explain that as we go through. A couple of slides just to outline that, the work that we've been doing with the TSA and partners over the last 12 months, and then a little bit of modelling to finish with. Nowhere near the data science levels that Steve was talking about, but still very impressive. Fantastic, everything's working, this is going so smoothly. So what is urgent community response? Urgent community response is a service that should respond to somebody within 2 hours of that referral being made. They offer support, treatment, assessment for very complex individuals, and the majority of people who receive urgent community response are over 65. Now you'll see on the screen up here the different kind of referral routes that we've got. Text responder services, are a key referral route. We also have a lot of self-referrals in from individuals who are well known to community care providers, but we've got ambitions to really grow the level of referrals that we are getting over 23-24 from tech responder services. You'll see in the second column, there's 9 clinical conditions that UCR services really should be responding to. So that's a national mandate. Some of them quite obvious clinical presentations, like falls, for example, like urgent catheter care, but some of them incredibly complex. So this is the type of population that UCR services can really benefit. People who are deteriorating quite rapidly, just aren't themselves. Again, probably elderly, may live within either their own home or within a care home. And the type of intervention that UCR services can offer is really, really varied. So it's a very holistic approach to care because it's multidisciplinary in nature. So the likes of individuals that you might see delivering urgent community response could range from podiatrists to geriatricians to nursing to AHP. So a really varied service, and that's why we call it a service. It's not a team, it's a team of teams. Now on this stand last year was Kath Evans, Deputy Director for UCR, who is unfortunately not able to be with us today. But Kath stood here and things were in a very different place for UCR. So as Matthew Wynne said in the plenary session this afternoon, if you were around for that, this service was developed and rolled out during COVID. So last year we had about 13,000 referrals a month in December. This December, 38,000. That's massive growth, absolutely huge growth. Now that might not be 38,000 individuals, but that's 38,000 care contacts, which may have resulted in either an admission to hospital or an attendance at an ED department, or even worse, a really, really poor outcome for that individual. What we aim to do with urgent community response is see everybody within 2 hours. That's why you'll often hear us referred to as 2-hour UCR. But we do have a minimum threshold of 70% of individuals to be seen within those 2 hours, and I'm really proud to say that we're nationally currently at 79%. So we're achieving what we want to do, but what we want to do is turn the entirety of that map up there dark blue, so everybody is seen within 2 hours. And that isn't just NHS England targets wanting to be met, this is about people receiving the right care, the right time, as rapidly as possible. And that's what's really unique about UCR services. So it sounds a lot like intermediate care, some might say, and it is, but it's that rapidity of response that manages risk, that stops the deterioration. So a little bit about the work that we've been doing with the TSA for the last 12 months. As Helen and Alison have already said, so I'll not labour the point, we did get the ask from Amanda Pritchard. We've got to do something about community-based falls. Falls are a huge driver of urgent emergency care activity, a huge problem over winter in particular. Falls themselves and the injuries that come with falls. So an expert reference group was set up. We were already working with our partners in tech quality in the TSA to understand what we could do to better support people in the community settings. And the community-based falls guidance was the outcome of that expert reference group. And that mandated every ICB in the country by December 31st, because we're very generous at NHS England and we like to give Christmas presents, to all have full geographic coverage of a falls response service for level 1 and level 2 falls between the hours of 8 till 8, which is also the hours that UCR services operate to. And I'm really proud of the work that we did. There was tech providers, systems, regional colleagues, all interested, all bought into the idea of what can we do to keep people safely at home and out of emergency departments. It's not just about the pressure on the emergency departments, of course, it's the benefits to individuals themselves. Who wants a trip to ED when you could stay at home surrounded by your own belongings? So really, really proud to say that that December 31st deadline was hit. All 42 ICBs at least partially implementing a falls response services throughout their footprint. And as I've said, this could be tech response services, community-based, trained responders, or it could in fact be UCR teams where that level of clinical acuity was a little bit higher. However, as often happens with NHS England, when something goes well, you don't fly under the radar for very long. So you'll see on the right-hand side of the screen there, just a snapshot from the Urgent and Emergency Care Recovery Plan. Two key things just to point out to you in the green boxes. One, a commitment to going further for community-based care, the expansion of urgent community response. So we are seeing more individuals in 23-24, enabling them to have better outcomes. And then secondly, the immediate scaling up of falls and frailty services, with falls obviously being a huge proportion of the work that we're all involved in. So it wouldn't be an NHSE presentation without some case studies, but I won't labour the point on this slide. What I'd like to draw everybody's attention to is the map. There is a huge section of the country already green. So green, as you'll see on the screen, UCR services accepting referrals from tech providers. So when somebody presses their pendant alarm, outdated technology, as Helen says, and needs that urgent response, tech responder services can get that rapid clinical support and advice for those individuals quickly and safely. It is a journey. You'll see Mole Valley to the top right of the screen, just starting to really work with the UCR service, build those relationships, as is so important, as Helen already outlined. But there's some super exciting work going on. Really, really exciting stuff. So you'll see Northwest Ambulance Service on the top left. Not only are they receiving referrals from tech responder services, but they're actually passing off their ambulance stack into tech responder services and UCR teams. So really safe clinical triage in that ambulance emergency control centre, then dispatching the right level of care for that individual's complexity. Really, really exciting to see that. Now a bit of modelling just to end on. Now this is from the Warrington programme that Caroline Williams talked about in her video, and Helen's mentioned as well. And this is a 3-month snapshot worth of data. So I won't go through the entirety of the slide, but of 107 people who tech responder services referred into UCR, 87% of them stayed at home. So previously, without UCR services and tech responder services working so closely together, those 107 people would have probably ended up on an ambulance stack, might have had a long lie, might have had a terrible health outcome, but 93 of them didn't go on to need emergency admission at all. That's an incredible outcome for those 93 people who were able to be cared for in their own home, surrounded by their own things, surrounded by the people that love for them and care for them day in, day out. That's 3 months worth of data. So if you do the maths on that and annualise it, that's close to 400 people a year in a place the size of Warrington, which isn't very big. It's a place, it's not a system. And what's really interesting about Warrington is they've got a very, very comparable over 65 population between themselves and nationally. So if that's replicable nationally ahead of next winter, I won't do the maths. The number's probably too big for me to say, but that is massive, massive gains, not only to the health and care system, but to the individuals who aren't lying on the floor for a long time, who aren't waiting for an ambulance response, who aren't being conveyed to an emergency department to have to wait. The pressure in the health and care system is there, but community-based care can really do something about it. You'll see on the right-hand side of the screen, that's just a snapshot from the operational planning guidance, which is released every year. If you're an NHS provider or an NHS employee, you'll understand the operational planning guidance is a bit like the Bible for the NHS. It's what we're delivering this year. Increasing referrals into UCR services is a key part of the operational planning guidance for us in 23-24, and that includes from tech providers. Now that was a bit of a whistle-stop tour, so if you do want to get in touch, if you want to work closer with your UCR system and you aren't perhaps connected at a ICB or even at a regional level, we can help with that. So there's some contact details on the screen there that I can see some folks taking photos of. That's great. The key piece of advice that I would say is if you're interested in working closer with your urgent community response services, join our Futures page. Futures has a range of contact details, a range of resources, a range of case studies to help you build the case for change. If you're not already doing this and want to do it, Futures is the place to be. You do not have to be registered with an nhs.net email address. It might take a little bit longer to get you accepted on the site, so explain why you want to be there. Everybody's very welcome. But I'll pass back over to Alison. Thanks, everyone.
We haven't got long left. It's difficult with these on, but this is just some incredible work. And what we see from Claire and the NHS is a real drive for change, a real drive that says we've got indicators in the NHS now working with us with tech responder services. Is there any burning questions? The lady? I'd just like to say who you are and who you would like the question to.
Hi, I'm Michelle Afanadakis from Cardiff Council. Mainly on the sort of the urgent community responder side. Sorry to pick on you. I know you've just spoken. Really, really great and interesting stuff here. How is that going to feed into Wales? Because this is where I'm quite keen. I've been sort of attending the Trailblazer sessions, really promising stuff. But I want to see that now come to Wales.
That's a challenge and a half, isn't it? Is this?
No.
Everybody can hear the mic now?
You can,
Fantastic.
yeah.
Hi. A challenge and a half considering my employer is NHS England, but one that I'd be really happy to chat offline about if you want to have a conversation. As I've said, Futures has got a range of resources on it. We've got published guidance on what a good urgent community response service looks like, the kind of conditions, as I've said, the referral routes, the governance, the patient safety, everything like that. So plenty of materials and examples that we can share. Let's grab a coffee.
Your colleagues, so Claire will be sitting at the gala dinner tonight, and your colleagues across in Wales are already, they've got a UCR type setup approach in Warrington, but then what you haven't got is your decision support tool. So together we are going to corral the troops. We've got a meeting tomorrow about how we bring it across to Wales. How can we bring the decision support tool? How can we learn from NHS England in terms of what we've achieved in Warrington? You have some special things that you're doing in Wales that we can learn from in England. So what we're going to try and do is get a much more collaborative approach so we bring the learning together. We are speaking to our colleagues in Scotland, but I think the relationship in Wales is much more strengthened because of what you actually have in Carmarthenshire and others. So watch this space. Yeah? Anyone else? No? I'd just like to finish off. So back to Claire. We've got that ambitious for 2023-24. You're saying connect to futures. Where's the program? What we're going to do? How are we going to do it? How we're going to pick up pace like we've had over the last 12 months? I know that I'm the chair of the steering board, but it's about looking at that governance and rolling it out.
Yeah.
So what we're going to do, Claire?
Great question, Alison. So we're thinking at the moment about how we meet those statutory responsibilities that we've got to keep providing UCR, keep doing it safely, whilst seeing that massive expansion that we did last year. So that tripling of referrals that we're seeing is really exciting for us. So what we want to do is start turning the map that I had on screen, that heat map with the case studies, even more green. Doing so in a way that allows tech responder services to get access into their UCR service. What we don't want to see, though, is sometimes what we're starting to see, and I said it is a journey, so this isn't a criticism, but sometimes a referral going into 999, then 999 having to pass that back to a UCR team. Obviously, UCR teams are set up locally. A lot of tech response services might be local, might be national. So it's really about that coordination of care and that single point of access. So if you are a tech responder service working locally, how do you know what your UCR number is? How do you know what their capacity is for that day? But that urgent care coordination hub approach is really, really exciting, because what it does is close the loop, joins all parts of the systems together, so it's right response, right time, first time. So we've got big ambitions about increasing our referrals, big ambitions to take forward the map, as I've said, to make it green and do it really safely. And that's the really exciting thing about this. It's all backed by clinical triage. It's all backed by clinical and non-clinical professionals who are there to care for individuals and do so in a really rapid way.
Thank you. I have a question for Steve. So Steve, you're a national monitoring centre. You've given us those insights for those fabulous data. What do you see from a readiness point of view, how you can roll this out? You've seen some greens on there. We can actually do it now, because what do you see the barriers now?
So I think, as Helen said, we have gone on an absolute journey. So having been involved in the pilot to begin with, I think we were contacting UCRs and they were going, who are you? Why are you phoning us? You shouldn't. And I think we went through an internal communication program to make sure that UCRs knew that we were on Service Finder, knew that we were using the decision support tool, and therefore they could actually accept our calls as a tech provider. Very much like your map, we have about 50% hit rate at the moment. In about 50% of cases are we able to use a UCR. The other 50% is a combination of we haven't got capacity.
Yeah.
This is not the right type of call that should be coming here, which I think is a learning we've got to do, because we've gone through the decision support tool to get there. So I think there's an element of education there. And some of them are you're out of area, which is interesting because we've used Service Finder to identify them. So I think we're starting to see a massive expansion of capacity, but it feels like we're not entirely there.
Yeah, it's a bit of a knotty issue, isn't it? I think geographical boundaries don't exist when you're talking about concepts and the right care for the right people, but they really do when services are commissioned.
NHS,
but
yeah.
it's definitely something that we can continue to work together on.
Brilliant. And my final question is, Helen, for every non-certified member in the tech industry, what's your advice to them?
Well, come and have a chat with us, most certainly. Myself, Anthony Anderson, Chris Pugh, we're all on the app. If you want to come and have a private conversation, then by all means book that in with us tomorrow. We're available. But obviously the benefits are there, is that you have all this wealth of information, this guidance, this support to get you on your journey, to make sure you've got the right foundations in place, and to help enhance and enable your tech responder service, as is your other service delivery modules that you might be certified against. So by all means, come and have that conversation with us. We're here to help and support you.
Brilliant. Any more questions? A decade ago, I came to TSA, and we've had problems with our ambulance services for the entire time, haven't we? But now we're seeing it shifting. Now we're seeing that collaboration's really working. And I thank all of our NHS colleagues for actually taking the time to understand our services and seeing the value of what they bring in the communities. And this is what we're seeing. The data's coming from our NHS colleagues. It isn't us saying this is brilliant. Our NHS colleagues are providing the valuation, the data, and they're seeing the value. So let's see, when we come on this stage in 12 months' time, a green map, fully certification across all responder services in the UK, and we're really driving change with our health colleagues. So thank you to the panellists. Thank you again for our colleagues in the steering group of UCRs, and thank you to our NHS colleagues. But more importantly, thank you to the tech responders and monitoring centres who've been persistent in knowing that their services are huge value to vulnerable people in the community. So thank you, everybody. Have a lovely night, and we'll see you live on stage tomorrow. Thank you.